This lecture will study regarding ECG. ECG, also remember, is known as EKG. So what is ECG? It is a graphical record of the electrical activity of heart, which is recorded from your body. William Einthoven, he recorded the first ECG in 1905. What did he do? He placed electrodes at different body positions. So Einthoven, he created the three bipolar leads. So he created the bipolar leads by taking into consideration the arms. So we'll just try to show that. So the right arm, right leg and left leg. So lead 1 was placed across right arm to left arm, where right arm was negative and the left arm was positive. Lead 2 was placed from right arm to left leg, where the right arm had negative charge and the left leg was given the positive charge. And lead 3 was placed between the left arm to the left leg, where the left arm was given negative charge and the left leg was given positive charge. So in this way Einthoven created the three bipolar leads: lead 1, lead 2 and lead 3. Lead 1 in right arm is having negative and in left arm is having positive. Lead 2 in right arm is having negative and in left leg is having the positive. Lead 3 in left arm is having the negative and left leg is having the positive. So this is how Einthoven first created the bipolar leads. There's something called as the Einthoven equation. This Einthoven equation says that 2 is equal to 1 plus 3, that is the potential record of lead 2 is equal to the potential record of lead 1 plus lead 3. That is why in all ECG we see a long lead 2 given at the bottom of ECG, so that it is easy to diagnose any condition by looking at long lead 2. So you can see this is a normal ECG. Even though lead 2 is given here, again at the end you will see lead 2 given again, that is long lead 2. The reason is because of the Einthoven equation, where he found out that the potential of lead 2 is more than the potential of lead 1 and lead 3 together. So that is regarding Einthoven equation and long lead 2. But even after this we were not getting the exact potential from one point, because the bipolar leads, so these lead 1, lead 2, lead 3, they are the bipolar leads having two poles, but we were not able to see from one point. So that is why Emmanuel Goldberger, he came up with the augmented unipolar limb lead. They are VR, VL and VF. But when he gave VR, VL, VF, we understood that it was not having that much amplitude. That is why we augmented it. We increased the amplitude and we got AVR, AVL and AVF. So here is where they have placed it. AVR, that is right, AVF, that is AVL, that is the left, and then AVF, that is the foot. So they were looking at the heart from the each angle. AVR, AVL and AVF, the augmented unipolar lead. So now what do you have? Yes, you have 6 limb leads, out of which 3 were bipolar that you studied previously, and now you have come across the 3 unipolar leads. But another problem came. We have to also look at heart in antero-posterior direction. The limb leads are not giving you an antero-posterior view. That is why we came with 6 chest leads that are going to give you an anterior-posterior view, and the 6 chest leads, they are from V1 to V6. So V1, it is present at the 4th intercostal space at the right sternal border. 4th intercostal space at the right sternal border. V2 is present at 4th intercostal space, left sternal border. 4th intercostal space, left sternal border. Then V4, it is present at the apex of heart, at the mid clavicle line, at the 5th intercostal space. At the 5th intercostal space, mid clavicular line, apex of heart is V4. Now you will tell me, sir, you forgot V3. So we'll put V3. V3 is present between V2 and V4. So you have V2, V3 which is present between V2 and V4, and V1 we spoke about. Then you have V5 and V6. Here you can see V5, it is present at the anterior axillary line, and V6 is present at the mid axillary line. So by doing this, we place the 6 chest leads also, that will give you the anterior posterior view. Okay, so I hope you have understood this anterior posterior view. These chest leads, they are the unipolar chest leads. They are called as the unipolar chest leads. They are also called as the precordial leads. Why precordial leads? Because the anterior chest wall that overlies the heart is known as precordium. Hence they are called as the precordial unipolar leads. So William Einthoven gave you standard the bipolar limb leads, Emmanuel Goldberger gave you augmented unipolar limb lead, and these precordial leads were given by Frank Wilson. So if MCQ comes regarding who gave what, so you must know. So now we are looking at heart, looking at the heart from all direction. Okay, but what about the posterior direction? So we'll place leads posteriorly also. So how will the patient be able to lie down? So we don't place the leads posterior. So to view the posterior part of heart, we will get the reciprocal changes. So just for MCQ, remember, if they ask you for posterior view, it is the reciprocal changes in anterior leads that you will see. So once you understood the basics about ECG, we'll try to understand the ECG and something regarding the leads. So many a times in your internship or in your posting, you must have come to know that they tell you, okay, this patient is having a lateral wall MI. So how do they come? Because there are ECG changes in the lateral lead. So lateral lead is lead 1, lead AVL, lead V5, lead V6. Now lead 1 is looking at the heart from this angle. Lead AVL is looking at the heart from this angle, and lead V5, V6 are looking at the heart from this angle. So they are basically covering the lateral wall of heart. Hence, if you have a lateral wall MI, you will have changes in lead 1, lead AVL, lead V5 and lead V6. Now if you have changes in the most common MI that we see a inferior wall MI. So if you have an inferior wall MI, it is lead 2, lead 3 and lead AVF. See, lead 2 is looking at the heart from here, lead 3 is looking at the heart from here, and lead AVF is also looking at the heart from here. Okay, here which you had AVL, AVR. So they are looking at the heart from inferior. So for inferior wall MI, you'll have changes in lead 2, 3 and AVF. Now if your consultant tells you it's a septal wall MI, then you'll have changes in V1 and V2, because V1 and V2 are covering the ventricular septum. Hence septal wall MI, V1, V2. And if your consultant tells you, okay, this is a anterior wall MI, so you will have changes in V3, V4, because V3, V4 is present anteriorly here, So for anterior wall MI, changes will be seen in V3, V4. For septal wall MI, V1, V2. For inferior wall MI, 2, 3 AVF. And for a lateral wall MI, 1 AVL, V5, V6. So AV3, AVR doesn't show much. So if a question comes to you that changes are seen in lead 2, 3 AVF, so which MI it is, then you have to remember this diagram is very important. Even if you conceptually understand the leads, you will answer the question, but this diagram also you must understand. Okay. So now we'll try to understand the waves. So normally you have a P wave, Q wave, R, S and then T. And let us draw extra wave. Sometimes you have U. So you have P, Q, R, S, T and U that is present only sometimes. So what does the P wave signify? It signifies the atrial depolarization. Depolarization, that means contraction. The QRS complex, it represents the ventricular depolarization, whereas the T wave, it represents the ventricular repolarization. Now some of you smart boys and girls will ask me, so where is the atrial repolarization? So I will tell you that the atrial repolarization is masked or hidden behind the QRS complex, hence it is not seen on ECG. That is the answer. Sometimes we get a U wave. Why? U wave can come sometimes due to a prolonged action potential of the ventricular cells, that is the ventricular myocytes, that can cause, or because of a prolonged repolarization of the papillary muscle. So if MCQ comes, rare it is to ask about U wave, but if it comes, then answer this question. So we'll just go through this diagram on your screen. So the P wave, atrial depolarization, then QRS complex showing the ventricular depolarization, and the T wave showing the ventricular repolarization. Depolarization was contraction and repolarization is relaxation. Atrial repolarization is hidden behind the QRS complex, hence it is not seen. So now we all know in the previous lecture we have understood that first from SA node the impulse goes to the AV node. Then you have the right and left bundle branch. But from the AV node the impulse first it will go to the left branch. That is, when impulse generates from SA node, it goes to AV node, and then from the AV node, when it is going to the bundle branch, it first goes to the left branch, and then via the interventricular septum, it goes to the right branch. So now we'll follow the impulse. Impulse generated in SA node, then it went to AV node, then it went to left branch first. So this left to right spread, which left to right spread, this left to right spread, it gives the downward deflection of Q wave. That is the reason why Q wave has a downward deflection. Okay, why Q wave has a downward deflection? Because of the movement of current from this interventricular septum. But some of you will ask me, but why down? Why not up? Because there's a law that in ECG you get a upward deflection. What is upward deflection now? This P wave is upward deflection, Q wave is downward deflection. So we are talking, you get a upward deflection when the current flow toward positive end. So when current is flowing towards positive end, you get upward deflection, and you get a downward deflection if current flow toward negative end. So when current was flowing from left to right, how was that negative? So we'll go back to the bipolar limb leads where right arm was negative, left arm was positive, left arm was negative and left leg was positive, right arm was negative and left leg was positive. So this was lead 2, lead 3 and lead 1. So this is the direction. So we'll give direction to this, like this direction, like this direction and like this direction. This was the normal direction of the leads. But now I am telling you that this is going from left to right. This is going from left to right. See, when it was going from SA node to AV node, it was all upward because it is moving in this direction towards positive. But when I told you it is now going from left to right, it is going from left to right. So this direction, when it is going from left to right, this direction is towards negative. That's why Q you got as a downward deflection. I hope you understand. It's a bit complicated. Just for your understanding, rarely a MCQ will come. So go ahead now. Okay. After it goes from left to right, then it again goes down. Okay. So this is think this is the heart. Then it again goes down in the down direction. So again when it is gone left to right and is coming down, again it is towards positive, and that is why you get a positive R wave. That is why you get positive R wave. So when the current flows down, it produces the R wave, right? Now, so it is coming down, it is producing the R wave, and now the base is starting to depolarize in this direction. So again it is now going in opposite direction. The wave is going in opposite direction, again towards negative, and that is why you get S also as a downward deflection. So when base starts to depolarize, you get the S wave, and S wave is having a downward deflection. Why? Because when the base is being depolarized, it is depolarized in this direction, and this direction is towards the negative. So that is why S is downward direction. If you understand, good. If you don't understand, very good. Go ahead. I don't think MCQ will ask from this. Just to get your base rate, I'm covering that. Okay. Now MCQs will come. What I'm talking. So now at the end of S wave, so S wave is getting ended here. At the end of S wave, the QRS complex is completed. That is, the ventricle now is completely depolarized. It is completely depolarized. So the end of S wave is called as isoelectrical point or J point. The end of S wave is called as isoelectric point or J point. So now the ST segment. What is ST segment? ST segment, it is the end of S wave, that is, it is from end of S wave to start of T wave. That is the ST segment. From the end of S wave to the start of T wave, that is the ST segment. End of S wave to start of T wave, ST segment. This is called as the isoelectrical segment. Why isoelectrical segment? It is because between these points all cells are in depolarized state, because QRS is completing depolarization and repolarization starting from here. So this much is called as the isoelectrical segment, because all cells are in a depolarized state. That is, they are equipotential. And then the repolarization of the ventricle, it begins with the start of T wave. So now we'll do an exercise where we'll try to calculate the heart rate by looking at the ECG only. So when you look at the ECG, you have to calculate the distance between two consecutive R wave. So the formula is, to calculate heart rate, is 300 upon number of large square between two consecutive R wave or the formula is 1500 upon number of small square between two consecutive R wave. So I want you to do a small exercise here. Count the number of large square. It is 1, 2, 3, 4. So 300 divided by 4 is equal to heart rate of 75 per minute, and yes, you have confirmed it is 75 per minute. If you count the number of small squares, just to make it fast, it is, now remember, there are 5 small square in a large square. So if there are 4 large square, how many small it will be? 4 into 5, 20. So number of small square is 20. So 1500 divided by 20 is also 75, I guess. So heart rate is 75 per minute. This way you will calculate heart rate. MCQ can come like this for you. The ECG, it has a paper speed when it comes from the machine, and that paper speed machine is 25 millimeter per second. The smallest box in the ECG graph is equal to 0.04 second, which is 40 millisecond, because sometimes they may ask you, or they can give you in the option as only second, and sometimes they may give you millisecond. So the small box, this small box is 0.04 second or 40 millisecond. As I told you, 5 small box will make 1 large square. So if 5 small boxes, if 1, 2, 3, 4, 5, if 5 small boxes is making 1 large square, so 1 large square, that will be equal to 0.04 plus 0.04 plus 0.04 plus 0.04 plus 0.04, that is 0.20 second or 200 millisecond. So 40 into 5, it is 200 millisecond. So once you have understood this, we'll try to talk regarding interval now. So there is something that you must know is PR interval. PR interval is from the start of P wave to the start of QRS complex. Though it is called as PR interval, it does not mean it is starting from P wave and ending at R wave. No, it is starting at P wave and it goes up to the start of QRS complex. It does not go ahead of that. So if you see in this image, PR interval is start of P wave to the start of QRS complex. That is PR interval. PR interval, it measures the time between atrial depolarization and ventricular depolarization. Just try to understand this statement. It is the measuring the time between atrial depolarization and ventricular depolarization. No need to mug up, just understand. You know P wave is atrial depolarization and QRS complex is this ventricular depolarization. So that interval is calculating the time between atrial depolarization and ventricular depolarization. So normally the PR interval is 3 to 5 small square. Normally it is 3 to 5 small square. So we will try to count here 1, 2, 3, 4. So that is normal. 3 to 5 small square. Okay, so it is given in the image of 160 millisecond. So 40 plus 40 plus 40 plus 40 is 160. something more we'll talk regarding this PR interval. This PR interval, it includes the physiological delay imposed by stimulation of cells in the AV junction area. So this statement directly I have removed from Harrison, that PR interval includes physiological delay imposed by stimulation of cells in the AV junction area. It is directly a statement from textbook, but now I'll tell you easy way. It is nothing but what it is showing the AV nodal delay, that how much time the AV node is taking to put the impulse ahead. See, SA node is here, AV node is here, and then the ventricles are here. So SA node, AV node, atrial depolarization. Now for the ventricle depolarization to start, this AV node has to put the impulse here. So this PR interval, it also signifies the delay happening in the AV node. That is what this statement is basically telling, that PR interval includes the physiological delay imposed by stimulation of cells in the AV junction area. If this AV nodal delay is more, the PR interval will be increased. If this delay is less, then the PR interval will decrease, and that is when we'll understand in the medicine part. So I hope you have understood PR interval, that it is showing the AV nodal delay in short. Go to QRS interval, because we are talking about interval, we'll finish interval. So QRS interval, you can see on your screen, it is around 0.08 to 0.10 seconds. So if you calculate, it is around 2 to 2.5 small square. So it is important for you to understand this 2.5 small square, because in pathological conditions this is going to vary, and that is how you have to catch. So to understand that, you have to first understand the normal. So I hope you understood QRS interval. Then we'll go to something that is called as the QT interval. QT interval is ranging from the start of QRS complex to the end of T wave. So it is basically involving the ventricular depolarization and the ventricular repolarization. So it is including these two things. Now just a fact to mention, you must know about this thing, because it is a bit difficult concept, so I don't think MCQ will come, but knowing this concept can help you to solve if MCQ comes. So QT interval, the duration, it varies, it is not constant, and it is inversely related to the heart rate. Inversely related. If heart rate increases, that is QT interval will reduce. If QT interval increases, that is heart rate is reducing. That is called inversely related. So hence when you want to calculate QT interval, it is a corrected value that we calculate. So hence QT interval is always shown as QTC, like that. That means it's a corrected value, and the calculation is, obviously you don't have to calculate, but just know the formula. It is QT upon the square, the root of bad at maths. It's the root of RR interval. For exam, just remember, normal QT is should be less than 0.44 seconds. It varies from women and women, but this is the mean. So remember this, QT is less than 0.44 second. Thank you. We'll continue with ECG and do revise.